As we jump into the nuances of building an interventional tendinopathy practice, we're going to kind of navigate this roadmap together tonight. So we'll cover some of the essential prerequisites that go into understanding and diagnosing tendinopathy and identifying patients that are appropriate patients for the minimally invasive tenotomy procedure. We'll also talk about what it takes to make that procedure successful and discuss some of the potential barriers that you might encounter as you're starting to build and grow your practices. So we're drawing on a decade of teaching and helping providers launch their practices, and we're here to guide you through a lot of the ins and outs of establishing really a thriving interventional tendinopathy practice. So we're going to start with training in musculoskeletal skills. One of the questions that we're asked really early on is, how do I know if I'm ready to do this as a procedure? Or you might be asking yourself that as you're going through and seeing more patients who are presenting with tendinopathy. From an evidence-based standpoint, there's the figures that are thrown around of 150 ultrasound examinations, 150 interventional procedures. It gives you enough of the basis of really starting to feel comfortable with, one, what you're seeing, and two, being able to localize a needle to the right place. Many of our fellowships now have a lot of this integrated. There's fellowships that have TenJet integrated from day one, and there's many of us on the call who didn't get this experience in fellowship, and we learned on our own. So please, again, all of the questions that you have, please throw them out. A really easy way to talk about am I ready is, if you know what you're seeing on the screen and you can put this thing here, you can do TenJet. Right, your ability of localizing a needle to targeted tissue is really the prerequisite that you have for starting to do this procedure. Doing it well is a combination of education and experience. And again, this is the format to be able to share what we've learned and what we found has been successful, what's helped us during that journey to really find proficiency in doing this procedure. But at a baseline, if you know what a common extensor tendon is, you can make this image show up on an ultrasound and you can see your needle into the tendon. You can do this procedure. From a classification standpoint, really this comes down to understanding where we've been. So before 1990s, we called everything wascitis, right? Everything's inflammation, and most of the treatments that existed were aimed at treating inflammation, rest and avoidance, some kind of DME, using anti-inflammatories, whether they're injected or orals, some form of physical therapy, and then when that fails, or the tendon ruptures or it tears or has high degree tears in it, you're going to go in and do an open debridement, or you're going to do a release. And then as we end up progressing through the 1990s, we start to understand that, there's a lot more degeneration than there is inflammation here. So we start calling things tendinosis, not just tendinitis. We have all the same treatments, but now we start doing dry needling, needle fenestration, and shockwave comes up as a treatment. Into the 2000s, we start to understand that, maybe there's not just these two separate things that present, and it's not just this chronic degenerative tendinosis. It really is a continuum, that there's these recurrent rounds, and these patients kind of sit somewhere in that continuum. The management there then includes Topaz that came out. Some of you on the call may have used that in the past, and then a large push on orthobiologics, for that being the panacea that's just going to fix everything in a tendon, create new tendon healing and regrow tendons. And we kind of know and understand where there's benefit and also some limitations there in orthobiologics. And then in the 2010s, really, this is kind of maybe our most current standing and understanding, is this failing healed response, that there's this continuum that happens, and there's the interplay inside tendons are a bit more nuanced than we may have understood, but we pretty much are still calling things either tendinitis or tendinosis, but we've added a lot more treatments, right? So we now have 10X that came on the market, TenJet that came on the market, and really with TenJet, we have something that can resect and remove tissue, and now we're seeing patients change in their response. So we know there has to be something different with their tendon. But even getting into the 2020s, we're still kind of using the same terms. We're looking at the tendon still in very similar ways, and more things are coming on the market to treat tendons. The takeaway here is that you have over 40 years of development in different types of treatments for tendons, not really significant developments in the classification of tendinopathy. So the way that we look at tendinopathy, and for those of you which should be just about everybody on the call, familiar with looking at musculoskeletal ultrasound, looking at a common extensor tendon, if you think about just taking a representational cross-sectional area across where these tendons are, you could understand where a healthy tendon that doesn't have a significant amount of tendinosis or hyperemia would have nice, densely packed, dense, regular connective tissue, all this type 1 collagen. Tendons that end up getting repetitively overloaded, you get neovascularization. We see this as hyperemia on power Doppler under an ultrasound. That's going to create some swelling in the tendon, so the tendon gets bigger. And then other patients come in with really no hyperemia, but a significant amount of this hypoechoic degenerative mucinous type of degenerative tissue that's inside the tendon. This is what we call tendinosis and what we consider to be tendinosis. And you can have a mix between the two of those. So approaching it that way allows us to at least see that these tendons aren't all presenting in the same way. The symptoms aren't always the same either. So you can have a normal tendon, a reactive tendon with a more propensity to the hyperemia, a degenerative tendon with mainly tendinosis, or that mix and that combined. And the importance of being able to identify this is that tendinosis, that mucinous degenerative tissue, is what is really something that you can use TenJet and do a minimally invasive tenotomy to resect and remove. So the whole purpose, if somebody asks, what is TenJet doing? What is the purpose of this procedure? The purpose is to reduce pain, enhance the function of the tendon by resecting and removing that pathologic degenerative tissue. And those, what we consider to be the type 3 or type 4 tissues, the tissues that have tendinosis that you can see on ultrasound, are the ones that respond best to this. So we're going to dive into the procedure a little bit more. We're going to break this up and kind of do a round robin and a little bit of a round table here between myself, Nate, and Chris, talking about the setup for the procedure, the prep, the feel, and kind of the meat and potatoes of the procedure, and then what to expect and to let patients know about the recovery. Again, as we go through this, please throw a ton of questions into the chat, because we will get to this as we get to the question and answer portion. So for setup, the most important thing here is everyone on your team being really read into what this procedure is. There's not a lot of parts to it, but understanding how to troubleshoot any of the parts, how to circle and circulate within the room really quickly, and having those who are going to be helping you really well read into the steps of the procedure is going to be the most successful part. A couple of other pearls. Pretty much everything that you see on the tray here in this sterile part comes in the kit, with the exception of the sterile drapes. Most of us use normally 10 cc's of some anesthetic, either Marcaine or ropivacaine. And then, your setup is fairly straightforward. The footprint is not very large of the TenJet console. And so having a Mayo tray, a TenJet console, and a bed that has just a little bit of adjustability is all you need. A couple pearls, what I found to be helpful is having a knee bolster like this is helpful for your quads and your patellar tendons. Put the knee at about 35 degrees of flexion and on tension. You can also take this thing, throw it behind somebody, use it as a shoulder bump. It can be helpful also for an elbow. So something to help just a little bit in patient positioning. And the other thing that I found probably over the last couple of years for hamstrings is approaching the hamstring in a different way. So when we do glutes, both the glute min and the glute med, depending on how the patient presents and where their pain is, whether their pain wraps from a more posterior to anterior direction, we'll go a little bit more in a transverse in-plane approach, versus if they hurt along the IT band and you're coming into that more inferior facet of the greater trochanter. This is pretty standard, I think, from the way most of us approach ultrasound-guided corticosteroid injections, and certainly the TenJet procedure. Hamstring, I learned it as the patient being prone and coming through this kind of inferior gluteal fold. Sometimes it can be really difficult, depending on where you are, your ergonomics, the size of the patient. Having the patient in a side-lying position, tucking their knees up to their chest and coming more superior to inferior, really easy way to catch that hamstring tendon proximally as it's coming off the ischial tuberosity. You have a really good look at the obturator internus, some of the gemellus muscles as well, and coming directly down there. I mean, I haven't had a patient yet in Ohio that we haven't been able to reach their hamstring tendon. So a couple takeaways for the setup and for the patient positioning. I'm going to hand this over to Nate to talk about the feel and kind of the next steps of the procedure.
Yeah, so for me, as this has evolved, as I've done more and more, I think one of the biggest pearls that I've learned is I spend way more time now sort of planning my approach using the local to hydrodissect the tissue to try to sort of identify what tissue I want to work on, than I do probably doing the procedure. It's, you know, as you see on the screen, I mean, you can, as you're inserting that local, you're going to get a couple of things. One, as you're inserting that local into the soft tissue, you're going to see in the tendon, opening up some interstitial tears that you might not have known were there. The fluid hydrodissection really helps you map out where you're at. And this is where I'll start to get a feel for the tissue, even with just the needle, in that I start to talk about a lot about sort of what the difference is in feeling tendinopathy tissue versus feeling healthy tendon tissue. And the way I usually describe it to residents, to fellows, to sort of learners is, when you put a needle in a healthy tissue, you should get relatively consistent but smooth feedback, and resistance through it. So I always liken it to sticking a needle in an eraser, right? You'll get some resistance, you'll feel that you have to push it, but it'll be consistent through the out. When you stick that needle in an area of tendinopathy, the first thing you'll feel is you'll get into it, it'll just sort of drop through. You'll feel this lack of resistance, this very soft tissue, and then you'll feel sort of a different tactile feedback between that coming in and out of the healthy tissue. So I'll use that to map where I'm going to do. It's super helpful for a couple of levels, right? It's very helpful to plan what you're going to work on in advance before you get yourself in there and plan your approach. It's also helpful because I would say that the more of these I've done, the less time I spend doing it. Early on, there's this desire to do more, do more, do more, be aggressive, and sort of what we term sort of overcook the healthy tissue, right? If you work too much that healthy tissue, then you're going to create more post-operative, post-procedure pain, more post-procedure soreness, and you're going to slow down that recovery timeline stuff. You're probably not going to hurt anybody. You're not going to do any danger. We know that there's great safety data on this, that it's not going to resect and remove healthy tissue. But if you jab that healthy tissue with the needle tip of this thing enough times, you're going to irritate it, and people are going to have increased inflammatory response around it. And then, you know, once we've done that and delineated the tissue we want to work on, it's making an exceptionally small, tiny little stab incision, not hubbing that 11 blade that you're using to make it. The more time goes on, the smaller the incision gets, the more pride I take on a smaller incision. Very important, I think, in working on a shoulder. If you're doing a rotator cuff, if you're doing a calcific or non-calcific tendinopathy in a rotator cuff, if you really hub an 11 blade to make an incision so you feel like you're doing something, you're cutting into deltoid muscle. And then you're going to immediately irritate and inhibit that deltoid muscle post-procedure. You're going to put more stress on the cuff because of that, and you're going to sort of extend that recovery period. So minimal incision. And then the device really is meant to be used by sort of a combination of pistoning back and forth, which I liken to, I started this in my career with just regular needle tenotomy, right? We'd be needling and working through it. And then if you look at the tip of the device, if you look at the second picture, you'll see that there is sort of that cutting window where it's drawing that abnormal density tissue in. So it's working that window in 360 degrees plane and rotating as you go to reach not just the same plane of tissue over and over. And you know you're done when now all of a sudden this tissue feels the same throughout. As I'm moving into these different areas, I'm not getting different tactile feedback. You'll see some ultrasound changes, but the ultrasound will always look somewhat abnormal. You're going to do some bleeding. You really want to feel that difference. Go to the next slide. And so once you've done, right, you've made a minimal incision, you're closing it, and that's when you start talking about, okay, what should I expect afterwards? What should my patients expect afterwards now that I've gotten the tissue that I want out? And Chris is going to talk about sort of how the phases, how we work through that.
Yeah, thanks, Nate and Dom. Great. I love speaking with these guys. I learn a lot from them, and it's been fun to do this over the last few years. And this presentation, I think, is a pretty unique one, taking you from beginning to doing treatments and building a practice. And so I'll reiterate, ask all the questions that you have and learn from our mistakes, and we can learn from each other. So as Nate was mentioning, I use during the procedure, as he's talking about, you know, how you do the procedure and how you're using the anesthetic to really set up what you're going to do. That's something I will echo, that I have really spent less time doing the procedure over the last 7-8 years and more time planning my procedure from a lot of different standpoints. You saw the room setup. One of the biggest things, and I try to teach my fellows and my learners that are with me, is you got to set yourself up for success first. And that starts with patient positioning and room positioning. So before we even prep the patient, a lot of times I will basically act like I'm doing the procedure without a sterile prep. I'll throw the ultrasound on. I'll, maybe set up the way I'm going to set up for the procedure, and then we set up the room accordingly. So that's an important pearl, I think, that, I've kind of honed over the years. And then while you're doing the procedure, you can actually talk about the recovery phases. So you have about 5 to 10 minutes or so where you're doing this procedure, depending on how much anesthetic you're using, how much you're setting that up, and how much debridement you're doing with the device. But I use that time to talk about these phases of recovery. And over the years, you can really see all these tendons and how they recover. And it's very similar across the body and across body parts and tendons. And there's an umbrella of what typically happens. And we divide it into roughly 3 phases. And really my follow-ups are based on that. But when I'm educating these patients during the procedure is initially the first couple weeks. Phase 1, call it the first 1 to 3 weeks. Our first follow-up appointment is at 2 weeks post-procedure. But really, this is our protective phase. And protective can mean a lot of different things. It can mean you're using DME to protect the patient. If you're doing a plantar fascia, you're giving them a boot. An Achilles, you're giving them a boot. If you're doing a patellar or quad tendon, you're giving them a brace. If you're doing hamstrings or glutes, you're giving them crutches, or potentially not any of that. Dom, Nate, and I have batted this around for years and spent a lot of hours discussing this. And a lot of times what we have settled on, or what we really have ultimately settled on recently is you protect it when they need to be protected, meaning Dom had mentioned the other day, if it's a really acute, angry tendon, hamstring in particular, he'll give them a crutch for a couple days. I offer patients boots, for the plantar fascia. A lot of them don't take it. I offer boot for comfort. So really, as we started doing these procedures and talking to these 2 gentlemen who have had a ton of experience as well, we protected a lot more with medical equipment, and we are protecting a lot less. But your comfort level is going to change based on how you treat these patients. So you talk them at week 2 or week 3, whenever you're seeing them back after the procedure. And let's say you do a plantar fascia, you give them a short boot, cam boot, and they come back at 2 weeks. And you ask them, did you need the boot? Yes, I needed the boot. How many days did you need the boot? I needed the boot for all 2 weeks. That doesn't typically happen in my practice. A lot of times I give people a boot, or when I was giving people a boot across the board for their plantar fascia or their Achilles, I found out a lot of patients weren't even using it because they didn't need it. They were ditching the boot because they didn't want to use it because they felt fairly decent after the first day or 2 after the procedure. So essentially, I went to really offering the boot to patients if they needed it and offering it for comfort. And so really, that's how my practice has evolved. And that's really how I use medical equipment during the protective phase, which is, again, the first 1 to 3 weeks. A lot of times, the most standard medical equipment that I'll use in the recovery for the first couple weeks, and Nate and Dom and myself have talked about this, is a cock-up wrist splint for our elbows. We've really found that elbow tenotomies can get kind of angry in the first week or 2 after doing this treatment, because as you've treated patients with lateral epicondylitis or epicondylosis and medial as well, or distal biceps, a lot of those patients, they have physically demanding jobs, or their life is physically demanding, so they're using their hand and wrist a lot to activate those extrinsic muscles of the hand and wrist, the common flexor and common extensor tendon. So using that cock-up wrist splint is important, and we use it particularly at night most often. So really, the umbrella for the first phase is protect and lay low, and let pain guide what you're doing in your activity level for the first couple weeks. Then we move on to phase 2, which is more a restorative phase. So we see them at 2-week follow-up. And a lot of times after I tell them at the procedure and after post-procedure, immediately post-procedure, how we are starting, how you're going to lay low and how you're going to protect, and you're going to use pain as your guide for the first 2 weeks. At that 2-week follow-up, when we see them in the office, we're really then advising on how do we restore function and activity, and letting pain guide our patients through that, and using gentle stretching, strengthening exercises. You know, if you want to add eccentrics and things like that for the hand and wrist and the elbow, it's really adding the exercise and the functional restoration during weeks 2 to 6 in my practice. You can extend it out to week 7. We see them at that 6-week follow-up. Again, to then progress to phase 3, where we're doing more active concentric exercises, rehabilitation type exercising, adding back function and adding back more muscle strengthening and balancing. And that gets to the point where we talk about, if you advance to the next 2 animations there, we can get into the reloading after the 6 weeks and beyond. How do you get patients back to what they're doing? The most common patient concerns at this time is, Dana had mentioned, tiny incisions. Sometimes patients are irritated. They have inflammation. They felt great for 2 weeks and they overdid it, and they have an acute inflammatory phase on top of their recovery phase. And so a lot of times that's the biggest concern that patients usually present to me at either 2 weeks or 6 weeks or 12 weeks during the recovery process is, I felt great, and then, you know, I did a lot and my issue came back, or I had some acute inflammation. They don't say that, but they describe acute inflammation. So that's the most common thing, and not to be scared of that acute inflammation, and treat that acute inflammation that happens with the patients with anti-inflammatories or icing, or, you know, medical equipment that really calms things down, especially overnight or during active phases. Crutching or not crutching, we already discussed that. Dom, do you want to kind of talk about your evolution with that at all?
Yeah, I mean, it certainly was an evolution. I think I crutched everything. There might have been arms I crutched at the start. Honestly, I think the initial conversation around, you know, you're going into this tendon, you're doing something to a tendon, I must be weakening the tendon, right? I have a high rate of probably rupture. Knock on wood, I mean, of those 5,000 cases, we didn't have that, right? And what we're actually seeing is patients were taking their crutches and saying, yeah, I used it for a day or 2 days because you told me to use it. It felt good. It felt better to load it. And so where really it was conversations with Chris and Nate and just kind of building the community of people with experience that said, you don't have to fear that. Tendons like being loaded. They need to be loaded in order to function the right way. And they probably need to be loaded to heal the right way. So it's really having a physical therapist who understands load management, they're worth their weight in gold, right? Because they're the people who are going to be able to tell a patient, you're pushing a little bit too hard here. Let's focus more on some isometrics for the next week. Come on back. So that really telling your patient that if you've been to physical therapy before, this is going to be a little different because it has to be. But having them immobilized with crutches, again, unless they have some significant hyperemia, again, mainly with hamstring, just because they're going to be sitting on it. I really won't put them on crutches too much. And again, I credit both the guys on the call for helping me kind of move to being a little bit more aggressive with getting them loaded earlier.
And I think you can settle on, thanks, Dom, for that input. I think you can settle on, you know, protecting it is not wrong, and protecting it with medical equipment is not wrong. But talk to the patients during their recovery, and you will realize that a lot of times they do not have to be protected or need to be protected as much as you think they do. We have the safety data that we're resecting the pathologic tissue and leaving the healthy tissue. And I think Nate had said it previously at some point during some of our discussions, you know, removing pathologic, degenerative, bad tissue that's not doing anything anyway is not weakening the tendon, because it wasn't, you know, providing stability or structure to the tendon in the first place. And that's what you're doing with this, with the TenJet device, is you're removing tissue that's there and not adding function or structure to the tendon to begin with. So removing that is not going to make the tendon any more weak or vulnerable than if it was in there. So that's kind of another reassuring tidbit to kind of give you. But protecting it is not wrong. And protecting more initially is a natural progression, but we're here to tell you, you know, with all our experience and everything, is you don't have to protect as much as you think you do, and really talk to the patients during the recovery process, and that will kind of shed light on that for you. So moving along to certification and credentialing. So Dom had talked about the training, we have the training, we have the musculoskeletal knowledge, we have the musculoskeletal ultrasound knowledge, we have the needle guidance knowledge. We gave you some tidbits on the procedure, and there's a lot more, and we can talk for hours and probably days and maybe weeks on, pearls and how we started doing one procedure, how we started, changed over time, and how we do different body parts, the same body part in different ways. We were talking yesterday about how we do medial elbows, and we all do it differently. And there's not a right or wrong way to do it. You position the patient and you get the device to the pathologic tissue. I always tell people that's the crux of the matter. If you get the device to the pathologic tissue and resect it, that is the correct way to do the procedure. And so however that goes about happening, that's the correct way to do it. So you're learning this stuff. You may have the question of, okay, so I want to do this procedure. I have the skills, I have the knowledge. This is something that can fit my practice, which this could fit all orthopedic and sports medicine practices for sure. But you might have the question, our specialties, some of us are family medicine trained or emergency medicine trained or physical medicine, rehab trained, pediatrics, internal medicine, whatever it may be. We're not used to going through the process of credentialing and certification a lot of times. We get credentialed to do our outpatient practices, but we really don't get credentialed to do procedures in an ambulatory surgery center setting or a hospital outpatient department, HOPD, or hospital setting. And so there is a process that is fairly consistent with that. And if you're doing these in the office, that is a possibility, but that you really can't recoup enough revenue and billing to make that a feasible practice unless you're using a cash-based practice. So if you're doing this in a ambulatory surgery center or a hospital outpatient department that recoup a facility fee, those two locations recoup what's called a facility fee, which pays for the cost.
Doing good? Doing good?
What can happen is that you need to get credentialed to do that. The hospitals protect themselves, the ASCs protect themselves, and they don't want people going in and doing procedures that they're not qualified and skilled to do. So there's a process involved in that. And typically that starts with the medical staff office. And this is an umbrella kind of a walk through that, but generally it's going to be very similar from facility to facility. Is you start with the medical staff office because you have to get credentialed. And there's a committee at every hospital system called the credentialing committee. And the requirements are going to be slightly different based on your hospital system and who's on the credentialing committee and everything like that. But essentially, if you have privileges and credentials as a provider at a hospital system, you need to request additional privileges to do this. And what that would involve is a form online or paper form where you're actually going to fill out a request for additional privileges, and you put needle tenotomy or minimally invasive tenotomy as your additional privilege request form. And typically you'll come back, you'll submit that to the medical staff office. They'll give it to the credentialing committee that meets every month, and then it'll come back with information that you need proof that you can do this procedure. So you either submit that right away or you wait for that to come back. Typically, they'll want a certification. If you've done this in fellowship or in a previous practice, they'll want patient logs. So how many cases have you done? What body part have you done? And is this in your scope of practice? At my hospital system, I was the first sports medicine physician, the first person to do this. I brought this to our credentialing committee and they had no clue what we were talking about, what I was talking about. So I was persistent in really going after the credentialing committee and really presenting them the safety data, the evidence, the fact that it was in our scope of practice, all the ultrasound guided procedures I had done, and really kind of beat down their door very frequently and very often at almost every meeting to really educate them. And so getting no the first time or getting a no or getting a we need more information is not a scary thing. Utilize us or those around you or Hydrocision in particular to provide your credentialing committee with the information you need. So they then give you the okay to do this procedure. And typically what that'll involve is you have the privileges to this procedure under a temporary status, which typically you'll need 5 or 10 proctored cases from somebody skilled in the procedure to sign off on your competency level. And so once you do that, you give those 5 or 10 or whatever the requirement is for your hospital facility or your ASC. They sign off on your competency to do the privileges, and it goes back through the medical staff office, the credentialing committee, then goes to the medical executive board a lot of times, and then the board of the hospital to sign off. And the process is not a quick one. It does take some time and it does take some persistence. But that's the general process. And once that gets approved through the board of the hospital, after it goes up through the ranks of the credentialing committee and the medical executive committee, then you are credentialed to do the procedure, and you can do it without any more proctoring or anything like that. You wouldn't be the first one to get this started at a hospital system on your own, so don't feel like you're going it alone. Really just be persistent. Know that you want to be committed to this procedure and committed to giving your patients the right treatment for tendinopathy. Know you are the one skilled to do this, and really educate those around you if you're doing it alone. If you have other sports medicine physicians in your health system that have gotten these procedures approved, that's all the easier for you. But that's a general timeline of what to do and how to go through getting credentialed with a health system, with an ASC, to actually do these procedures in a facility that actually garners a facility fee that pays for a lot of the products. After you get that, then you add it to your malpractice insurance. I'm a family practice trained physician by my primary training, and I had family practice-based insurance, and it did not increase my malpractice insurance at all, but you really want to let the malpractice insurance provider know that you're doing these procedures. So then moving on to patient recruitment. And so you're now credentialed to do this. You have your proctored cases, you're all set up. How do you recruit these patients, or how do you get these patients from your office to the procedure room, through the recovery phase, and to normal functioning, back to their prior level of functioning with little to no pain? It really starts with you convincing yourself that this is something that you can do, and really talking, to a lot of physicians about this procedure, about doing minimally invasive tenotomy, about resecting pathologic tendon tissue. We are the specialty that is best trained to do this. Orthopedic surgeons are not trained in ultrasound. They maybe don't even understand pathologic tendon tissue completely. When you talk about lateral epicondyle, there's 20 treatments for lateral epicondylitis and lateral epicondylosis. That's because it's very poorly understood. But what Dom was going through earlier with the tendon classifications, as we're starting to hone in on which tendons respond to which treatments, that's our specialty. This is our niche. This is how we fit into orthopedics and sports medicine. This is where we provide value and skill, and we are the ones to treat them. So convincing yourself that you are the physician to treat these tendons is pretty much the first step in patient recruitment and building your practice. And so if this lecture has not convinced you of that, seeing patients and throwing ultrasounds on tendons may eventually convince you of that. Because a lot of times the other question we get is, where does TenJet and where does minimally invasive tenotomy fit into my treatment algorithm? And Nate has talked about this before. I've heard him talk about this before, is he used to start this in his treatment algorithm, but it was lower on his treatment algorithm. He would try corticosteroid injections, orthobiologics, physical therapy, DME, home exercise programs, NSAIDs, topical NSAIDs. And minimally invasive tenotomy was part of the treatment algorithm, but it wasn't high up on a treatment algorithm. Dom had gone through a very nice description of what we're looking for on ultrasound and how we can diagnose these tendon problems. And if you see that pathologic tissue, minimally invasive tenotomy is the treatment to get rid of that pathologic tissue. Dom said something the other day that was very poignant. I liked it. It was very eloquent. If we treat your symptoms, meaning using corticosteroid injection or bracing or something like that, if we treat your symptoms come back. If we treat the problem, which is the pathologic tissue, then your symptoms will go away. And so really bumping up minimally invasive tenotomy to a higher up level on your treatment algorithm, don't wait to do it. I think that's the take-home point with this, is don't wait to offer this treatment to patients. We are the ones that are able to do it. We can guide the needle to the location. You're only going to get better with time and practice. You're going to hone your skills. Talking to more people that are doing this, you're going to improve. Start treating these tendons and start treating them earlier on, because by the time they see us, a lot of times it's 6 to 9 months of conservative treatment or longer. Sometimes it's years. making them suffer, these patients suffer through more conservative treatments when they have pathologic tissue, and it's going to end up in minimally invasive tenotomy. Begin performing minimally invasive tenotomy and do it sooner, because that's how you're going to get these patients better. You're going to keep them in the practice. You're going to garner confidence in yourself. Patients are going to garner confidence. You're going to generate referrals that way. So really bump it up your treatment algorithm, and also meet the patients where they are. And if you have a patient that isn't able to undergo minimally invasive tenotomy because of timing, it's golf season coming up. You know, I'm in central Pennsylvania. We got 4 months to golf. So patients really are opting against doing some of these procedures during this time of year and pushing these off to the fall and the winter time, offering them treatments to get them to minimally invasive tenotomy to actually fix the problem, and really educating our patients, showing them the ultrasound, showing them the pathologic tissue, showing them that hypocoat tissue that's at the bone tendon interface, really making them partners in the treatment and the plan, and the decision to do one of these treatments is massive. And most patients, I don't think I've really ever had a conversation with a patient where I give them an injection that is temporizing, whether it's Toradol or if I'm using, you know, something like a low-dose corticosteroid or something like that. Hate doing it, but you know, sometimes we do it. We do it if it's inflammatory. A lot of times, if you're offering them those treatments and you treat them, and you know they have degenerative tissue, and the patient comes back into your office 2-3 months later, and the pain return, felt great for a couple months, and the pain return, which is something we hear over and over again from our patients, it is not a hard sell to tell them you can fix this problem, you can remove and resect this degenerative tissue and fix the problem, and they don't have to come back and see you anymore for that problem. They'll probably see you for another tendon in the future, but not that tendon and not that problem. So really meeting the patients where they are, educating them, partnering with the patients about the available treatment options. And the reason to do the minimally invasive tenotomy is because we are fixing the problem, is really an easy sell to patients. And once you understand that, and hopefully this lecture can really guide you and instruct you into understanding tendon pathology better, then you can really partner with your patients and make that happen. So you know more than you think you know, and you're able to do this, and you start treating these patients, and you see the pathologic tissue, resect it, remove it, and fix the problem. So now we've talked about, you know, by getting patient buy-in, recruiting patients, you know, buying in yourself as a physician to do this. And so you do the procedure and you perform the procedure and you build the procedure. And that's a very, very important component of this whole process and this whole continuum of how you build your practice. And so Nate has a nice perspective from a private practice to a hospital employed physician now, and he can talk a little bit more about billing and coding, which is a very essential component of what we're talking about tonight. So Nate.
Yeah, obviously you can't get paid for it. You're not going to get anybody better. You're not going to keep a practice open, and that's important. As Chris was saying, I spent the first decade of my career in private orthopedic practice, where the dollars you bring in essentially define the voice that you're going to have in a group. So this was an incredibly important part for me in growing a practice. And I don't want to rush through this, but I want to keep us on time enough that we can hit some questions as well. For me, the most important things from a billing coding standpoint are, look, there are tenotomy codes that exist. I'm not going to go over every one of them. If you have questions about them, there is certainly resource available from HydroCision to help discuss those codes. The codes exist. The important part to the codes, and I don't want to jump ahead, but I already saw in the chat a little bit people questioning needle tenotomy versus this and the need for an incision, and discussing billing questions. It's really important, and I think the crux of coding and billing is describing what you're doing in your operative or procedure note in anatomical and surgical terms of what you're doing. And the important part for the coding of these and the tenotomy codes are, one, that you are making some degree of an incision, however small. That's less important to me from a billing standpoint, in that it makes access dramatically easier with the device. And that's the main reason I do it. But two, describing that you are removing and resecting tissue. And that's what we're really doing here. We're removing debriding, degenerative, non-functional tissue. And including that wording in your report is what justifies the surgical codes that you're using. And this is the device that's on the market that has been proven to resect and remove that tissue. Other needling techniques don't remove and resect that tissue. They're needling. The argument of a little bit stuck in the end of the needle doesn't hold suit for me. And you're literally removing that. So that's the important part of talking to a coder or a biller about the codes that you're using. These typically get authorized in advance. Haven't had much difficulty getting them authorized at all. I usually say I can't remember the last time I had one not get authorized, but 2 days ago I did and had to do a peer review for it. And the important thing for me there was, by the time I got the peer review on the line, the doc that I was talking to said, "Hey, I did some research on this problem. I see that your patients failed conservative care. So for me, it's either you get rid of this bad tissue or they live with this problem forever." So there's an educational piece there. I mean, when if you're talking to someone for approval, the discussion really is this is the disease and this I'm going to get rid of it. And that's the important part about getting paid for what you're doing, is describing what you're doing. So you describe the medical necessity in your note and the anatomy of the disease that you see, really just documenting your diagnostic ultrasound. And it's an opportunity to educate. It's an opportunity to educate both anybody that you need to from an insurance company standpoint, and your billers and coders, having this open discussions with them about this is what I'm doing, this is what my op report says I'm doing, cuts down on difficulty with billing and coding. We'll go to the next slide. So that ties in really well with sort of growth and expansion, right? So you could easily, I think, in any geographic area, have a practice that was only tendinopathy if you wanted to. The burden is so high, 5% prevalence in the general population. We've got data to see. It's out there. It's everywhere. And we are the subspecialty that's best positioned to deal with this problem, both from a diagnostic and from a management standpoint. As someone who has worked extensively just in the orthopedic surgery world, my opinion on the best way to approach that is just educational, right? I switched from one private practice to a bigger private practice about 6 years into practice. And the conversation really was, I talked to one of my surgical partners and say, "Hey, you've got this patient who's been in 4 times and had steroid injections for chronic recurrent trochanteric bursal pain, as you're calling it. What do you think's really going on here? And what would you do about it? What are your options for treating this?" And discussing tendinopathy, which, most orthopedic surgeons are well in tune with, but what's your solution, right? And open debridement, and open release, and open repair. What are your success rates with that? They're not very good. I don't have a better option. And then the discussion of, well, I do, and here's why. And it takes 2 or 3 chronic patients that aren't getting better that you got better, and all of a sudden you're the guy, right? At this point, I get into referrals of patients that are primed and ready to go from my orthopedic surgeon partners, from the hand and elbow specialists, from the shoulder surgeons for calcific tendinopathy, from the hip joint surgeons for chronic lateral hip pain. Educating your colleagues on what you're doing and how you're treating it, and as a viable option for something that they don't typically want to treat and aren't effectively treating, is super helpful to grow. Same with physical therapists. They're seeing these patients that are failing physical therapy, chronic lateral hip pain, that they're doing everything they can for and getting better. You get referrals directly from them. And I think educating colleagues and then educating other treatment options in the area really helps. And then patient education, right? The Hydroprecision, I think, has done a good job of some direct patient education on tendinopathy. Informed patients now find me coming in and saying, "I want this procedure done. I've done my research. I know I have tendinopathy. I have imaging that shows it. I don't understand why I'm continuing to cover it up when I can fix it." And when you get buy-in from other providers, it grows exponentially. I think that if it was all that I wanted to do, I could do this all day, every day, and be busy. Go to the next slide if we can. So that was sort of a run through of sort of growing practice. We wanted to save some time, particularly to work on questions in the chat and then open it up to questions. I touched on a couple of these, but there's several questions in here talking about the choice between PRP and minimally invasive tenotomy for tendinosis, how this fits in the algorithm, how they tie together, when you would choose PRP versus at MIT for tendinosis. And Dom, I think you speak well to this. I think it ties in well with some of those pathology slides you showed earlier. If you want to take that.
That's fair. You know, I think when we started looking at a lot of the research, and anybody who's asked this, that's looked at PRP research, typically it's for common extensor tendinopathy, and you see a relatively well-designed study that showed that PRP, typically leukocyte-rich PRP, is effective. And then you look at a very similar study that's designed that shows it's not. It's the hyperemia that really is the thing that responds well. And we can have a long conversation about why we think that is. These are tenuous small blood vessels that end up, it's almost like a sclerotherapy for closing down those blood vessels. I would venture to say that if you took a tendon that did not have hyperemia, no significant hyperemia, and it was tendinosis, you might get some minimal improvement of it, but it's not the same improvement that you get with patients with significant hyperemia. That's because the treatment for hyperemia is getting rid of the hyperemia, scarring that down, closing down those blood vessels. Potentially removing the tendinosis might lead to a little bit of a removal of that hyperemia, and down the road that resolving. But the treatment is tied to the pathology, which is why TenJet treats degenerative tendon tissue. It resects and removes it. And for those of you that do any of the other procedures and feel that it is effectively resecting and removing it, let's have a discussion about that, because I feel fairly confident in saying this is the only thing on the market that actually resects and removes. Doesn't emulsify, doesn't shake it around, does not pass by the tendinosis. It removes it. And so it's a good opportunity for a conversation on it, but PRP orthobiologics are effective for hyperemic tissue, not necessarily degenerative tendon tissue, from the theories that we have and the way that we apply it. Hopefully some controversial things thrown in there to generate some more conversation, but that's why we're on a call.
Thanks, Tom. There's a couple questions here that I think tie together that I'll just sort of speak to quickly. Somebody asked about being proctored, and if they're the first person to do it in their system. Chris speaks to it similarly. I was proctored by a hand surgeon. It was in my group that had no idea what I was doing and said, "Don't screw this up. I'll be in the OR next door." They'll find a person that is close enough to understanding what you're doing to proctor you, that you probably already know more about this procedure and needs to sign off your privileges. Because I think you got proctored by a different subspecialty even.
Plastics, yeah. And it was you go through the process and you find a physician, or the credentialing committee will find a physician that does something close. And I've started a lot of procedures in our hospital system, or not started, but I've been the first one to do them. And I haven't had proctoring physicians, but have been proctored by physicians. And so you actually educate while you're doing the procedure. And so it's not a foolproof process. It's not, you're supposed to be proctored by someone that can actually do the procedure. But if not, you work with the credentialing committee. You don't stop until they find somebody to proctor you, because there will be someone that will proctor you. But a plastic surgeon did mine, didn't know ultrasound at all. I was explaining what I was doing. I was teaching him while I was doing it. I was also learning myself. But the safety of this device is absolutely reassuring, where you're not resecting, you're not damaging, you're not in any way harming the healthy tissue in an irreversible way. And so you can be confident that you're doing this treatment and you're not doing more harm than good.
Yeah, and there were a couple questions on, someone said, is this a permanent thing? Is this, what's the maximum number of times you would offer a patient TenJet? I mean, you're removing and resecting this tissue, so it should be a permanent thing. There shouldn't be the need for repeat procedure. You shouldn't need to be going back and doing it. And if you're getting the tissue that you're looking for, it should be permanent. The only times that there are caveats that I would speak to are, then afterwards looking at, okay, what are the risk factors of why we developed this to start with, right? Does a patient have a functional movement abnormality that caused it? Are there biomechanic pieces that caused overload of this glute tendon? That's the afterwards. We want to start strengthening. We want to start our rehab stuff. We want to identify why we ended up here and correct that. And yeah, if you don't correct that, over several years, you could develop more tendinopathy from chronically loading that tendon inappropriately. So, but it should be a permanent solution if you're addressing underlying biomechanics afterwards, which I think is an important part conversation that I have with patients of, it's you've got a problem. All right, let's fix your tissue. Then after we fixed your tissue, let's fix your function, and that's what keeps you better. If you've got a tissue disease and you're just trying to fix function, that's probably not going to be enough. And that's why patients fail physical therapy. And that's why the conversation is PT after this procedure is you failed PT, but PT after this procedure is not treating the same thing that we were treating before. It's cleaning up movement patterns. You failed before because you had a tissue problem that wasn't appropriately being addressed. And I think that's an important point to make. Chris, people ask about the combination or choice for combination of PRP and MIT, sort of the decision making of should you do both? Should you do it in combination with prolotherapy? Should you do it in combination with PRP? I think you and I have very similar thoughts on this, but I'll let you speak to it.
Yeah, I think the question is, should you do it? Can you do it? Absolutely. Should you do it, or do you need to do it? Is I think another question, and I think that reverts back to the point of what are you actually treating? Are you treating tissue that is both degenerative as well as hyperemic and inflammatory, or is it purely degenerative? So really relying on your tendon classification is extremely important, and that's the discussion we have when I'm booking something for somebody for minimally invasive tenotomy. We're having that discussion. Are we doing minimally invasive tenotomy? Are we doing an orthobiologic injection? Are we doing rehab? What are we doing? And really that hones in around what pathology are we treating. So really understanding the pathology and what you're actually treating will answer that question for you. Can you add PRP to anything? Absolutely, you can add PRP to anything. Should you? Well, that's up to you. If you have to do it. And so really what I've settled on is if it's a degenerative tissue or if it's a mixed tendon where it's hyperemic and degenerative, typically I'll present the options to the patient. Or a patient comes and asks me, what would I do? So if I'm having that conversation with a patient, we're deciding between orthobiologic injection and they have a degenerative tendon. We're deciding between orthobiologic or minimally invasive tenotomy. I explain the pathology. I explain why we need to resect that tissue, show them an ultrasound. And typically what will happen is we're resecting that tissue. We're doing the minimally invasive tenotomy. We're using TenJet. We're resecting the pathologic tissue. And we're revisiting typically at week 6. Do we need to add any augmentation in terms of platelet-rich plasmic injection or orthobiologic or something like that? So I, at one point, would mix the biologics with my tenotomy procedures. And by and large, what I found, I had a period of time of a couple of years where I didn't do that. I had a period of time of about 6 months where I did do that. And what I found by and large is those patients were very inflamed at their follow-up appointments, more so than I had recalled before. And I don't have anything other than experience behind saying that. And so really what I reverted to is really relying on tendon diagnosis, pathology diagnosis. And really, if it's a degenerative tissue, then I'm leaning more toward the minimally invasive tenotomy with saving an orthobiologic injection in the future if they've inflamed or I've irritated it with the procedure sometime at week 4 to 6 post-procedure. If it is hyperemic and inflammatory, then that is a legit, I will lean the other way and I will lean more toward an orthobiologic injection or something to sclerose or shut down the neovascularization that has happened in that area versus irritating it more with minimally invasive tenotomy if it's purely hyperemic or inflammatory. So really, I've kind of evolved my practice over the years through some mistakes or suboptimal treatments, I would say, and really diagnosing that tendon pathology and understanding what you're looking at with ultrasound is the crux of how I'm recommending to patients. But if the patient comes in and wants to try PRP and they're purely degenerative, I really don't, I maybe advise against it, but I will perform PRP for those patients. And a lot of times we're ending up cleaning up the tissue as well and resecting the degenerative tissue in the future at some point.
Yeah, I was doing both combined for a long time. And then I stopped and I found that patients are doing just as well without the PRP unless they're really hyperemic. So the experience was similar. A couple questions about the comparison between this and 10X and other devices and sort of what's going on. And we touched on specifically the mechanism of action of this, and there's some differences there. Dom, I think you talk great about that. You've got some very interesting visuals, I think, that go along with it at times. So maybe you want to touch on that a little bit.
Yeah, I'll jump in there. We get these questions quite quite a bit. And for those of you, I had 3 years, 4 years of using 10X before switching over to TenJet. So there's a couple features that are different, and some of the things that helped me switch over. One of them is the overall length of the device, and I'll be kind of quick with this. We can always talk, and you can get in touch with Sunil and other people where we can jump on and talk in a little bit more detail. It's a longer device. It's a thinner caliber of a device. I can reach just about everything that I need to with the TenJet device, and this is compared to a TX2. From the ability of resecting and removing, pretty much anything that's going to happen at the tip of the 10X device can be removed, but because you're using fluid as the outer lumen and then sucking through the inner lumen, it's not incredibly effective. If you've used 10X, you've become very very good at tapping the pedal, because you got to start and stop because the end gets occluded very quickly. Versus TenJet, that stream of salines creating a venturi suction that pulls things in through that window. You look at this, that suction power is incredible compared to 10X. The benefit of this is only things that can fit through that cutting window are going to be able to be resected. So there's a lot of calibration that went into how large is that and wide is that cutting window, so that you're not removing healthy tissue, you're removing that more mucinous degenerative tissue. If it fits through the end of the 10X device, you're going to resect it. You can go right through cortex of bone with it, and that's how they developed that TX bone. The other thing is the efficiency at which it removes fluid. So if you turn on 10X, you're going to get fluid that's going to be reserved within layers of tissue that tends to cause some swelling afterwards in some tissue that remains there. TenJet, because you're using the fluid as the resection and removal mechanism, you're removing that fluid at the same time. So just to kind of review all of these, it's a different mechanism of action. 10X is an emulsification device. It's not a resection and removal device. It's not selective for the tissue. It also gets hot, right? It's metal pieces that are passing by each other, right? So if you've used 10X, you have kind of a limited time of using it before it's going to get warmer either in your hand or on the tissue of the patient. The other thing is breakage events. So the FDA has the manufacturer user facility device experience records of anything that happens. If it malfunctions, if pieces come apart, if there's something that happens, you can go on and take a look at this. There's over 500 events for 10X. There's nothing for TenJet related to breakages of the device. So it's a different procedure together, even though what you're doing looks similar. It's under ultrasound. It's a needle device. It altogether is a different feel as well.
Thanks, Tom. The global period, as was just asked, for most of these are 90 days, with the exception of Achilles tendons, which I believe is 10 days. Guess correct me if I'm wrong. There's a 10-day global for an Achilles and a 90-day global for everything else. There's a question regarding blood thinners and a question about NSAIDs. So I don't stop blood thinners when I do these. I did two patients today who were on Coumadin, both 2.5 goal and up. A little bit of bleeding at the site work on is not harmful, probably helpful, because we're talking about poorly vascularized tissue, poor blood supply tissue to start with. You're localizing well, you're not removing healthy tissue, bleeding is minimal, and there's not a lot of concern for that. I've never stopped any blood thinners. Same effect. I don't stop NSAIDs afterwards or beforehand for that reason. Somebody asked if we've ever done TenJet on somebody who had surgery for lateral epicondylitis and continues to have extensive pain. Yes, I've done it. I've done it to patients post rotator cuff repair. I've done it to patients post extensor tendon release of the elbow, because we're treating a degenerative process, and I think that is very helpful. Then I believe, let's see what I missed here.
There was a question, Nate, about would it be possible to do TenJet without an assistant? And I'd be curious to hear your thoughts. My thoughts are yes, you could do this without an assistant. It wouldn't be efficient. But this is coming from Julia. Hi, Julia. Good to see you on the call.
Yeah.
Someone who is in a very small practice with only one employee, and if they're out sick, can they do it by themselves? And I think if you familiarize with the device, which you should, and the setup, it wouldn't be the most efficient way to do it, but you absolutely would be able to do this yourself with a sterile Mayo stand right next to you, with all the equipment laid out. I don't know what your thoughts are, Dominate, on that.
Yeah, I mean, I do it with one medical assistant, so it's just the two of us in the room. It's especially if you're doing a little bit higher volume, you probably need somebody else to be able to be the sterile while you're non-sterile, or you're sterile and they're non-sterile. That does help to as you open up the kit and you have the sterile parts in your hand, and you're handing something to someone to plug into the console and then be able to put into your IV bag. You would be doing a lot of kind of gloving on and off and on and off. You could do it, but for efficiency, at least one person's probably recommended.
Yeah, and maybe I'm a diva. And this speaks to some of the, there's not one right way to do this. I do all my cases in an outpatient ASC. I offer my patients Twilight if they want it for most of these. A lot of them take me up on it. So I've got a circulating nurse, a scrub tech, somebody floating around, somebody to control my music if it gets too loud or a song comes on I don't like. I've got, a nurse anesthetist there when I'm using Twilight. And it's nice because one of the practice efficiency things about building a practice and being effective at generating revenue is if you can stack cases together and move through them, you're going to produce more revenue doing this. So if I do these in a half day, I'll come in and do 12 of them in a half day in the morning. They're booked at 30-minute intervals, including room turnover time or less. I found out today they're actually not 30-minute intervals. They're 15-minute intervals that patients are showing up for. But you can, with help, you can move through these quickly. And if you can book 8, 10, 12 of these in a half day, that's certainly financially worth your time by a lot to do them. And it helps with proficiency and practice. Ideally, the first day you do these, you want to stack at least 3, 4 of these together to get yourself in the mode of doing them to make it equitable. I mean, you could do one at a time, but it's better for flow to stack them up, and more help, I think, is helpful for that.
So we settled on you can do it, but it's not ideal.
Yeah, I mean, I like to say,
you are a diva too, Nate, but I am a little bit too.
I feel like it on Wednesday mornings when I'm doing them all the time, but sometimes I like that feeling.
Can we talk about the permanency of doing minimally invasive tenotomy to get rid of tendinopathy? Talk about your experience and repeat customers, so to speak, and who those customers are.
Yeah, I mean, there's a couple of pieces there, right? Without a doubt, there's a genetic predisposition for, I think, some degree tendinopathy, and absolutely, although I don't know what it is, for calcific tendinopathy, right? I think everybody or all of us at least, and probably many of you have seen somebody where they come in, they've got calcific tendinopathy, the rotator cuff, you deal with it, it gets better. They're back 6 months later with the same thing in their other shoulder. You see them a year later, they've got a calcific tendinopathy in their common extensor under their elbow, or they've got, the glute tendon. I've got patients where I've taken 5, 6 different calcific tendinopathy out of different areas, right? It's not recurring in the same area, but I'm treating patients in multiple body parts with the same technique because there's a propensity to develop some of these things. And I don't know that we know, or maybe I don't know, and somebody else does, what that genetic propensity is, but there's got to be there. There's no doubt in my mind. I can tell you that in the cases that I've done, I've had a handful, and I could probably count them on one hand, of repeat tenotomy patients where I did a hip on somebody 7 years ago, and they were great for 5 or 6 years. And, it's a woman in her 70s who comes back and goes, I didn't do any of the PT you told me to afterwards. I didn't strengthen at all. My hip was great, so I didn't think I needed to. And it's starting to come back. And every time that's happened, which I could count on one hand, the patients looked at me and said, I just want to do the same thing again. It worked great. It wasn't bad. And so that was probably my downfall of not appropriately rehabbing someone afterwards rather than strict recurrence of disease.
That kind of goes into one question was the optimal frequency for TENJED or minimally invasive tenotomy, let's say, and is there a maximum number of tenotomy procedures you would recommend for a patient? So I think from an optimal frequency standpoint, let's say we're not talking about the same tendon. Let's say we're doing bilateral lateral epicondylosis in a patient. I separate mine, for instance, or bilateral glutes. I'll separate mine by 2 weeks in between, typically, if I'm doing bilateral. if that's answering the optimal frequency tenotomy question. And is there a maximum number of procedures? I joked with Sunil at one point. One of my patients needs a plaque of some color or metal or some earth metal because of the number of TenJet procedures he's had on different body parts. I don't think I would say 2 weeks in between my procedures if I'm doing bilaterality. And I don't really think there's an a maximum number of tenotomy procedures for a patient if we're talking about different tendons. If we're talking about the same tendon and you keep treating them with the same treatment and it's not getting better, I wouldn't do it more than once if it's not improving their symptoms.
Yeah, in those, I'll say the caveats there may be if you have some people with really resistant calcium deposits, you might be going back in if it didn't fully resolve and getting after some other ones. I do have one patient who he had a 9 cc PRP injection into his patellar tendon at a different facility, came to us incredibly degenerative. We ended up doing 3 TenJets on his patellar tendon over the course of 4 years. Really nice pre and post ultrasounds in there. That's atypical, right? There's been maybe a handful of patients that we've repeated them. And I think, Nate, the way that you said, there's a history there, right? There will be a field in the future. If anybody on the call wants to really look into it in terms of tenogenomics, like there's genetic precursors that would make people more apt to getting tendinosis than others. But yeah, no, I agree with Chris. Very, very rare that you're going to be repeating these significantly.
What are your thoughts on if you're doing like bilateral gluteal tendons?
Yeah, I wait 6 weeks. The reason I do 6 weeks is because I like that they've had enough physical therapy to understand what appropriate loading is. So then they don't have to learn that a couple of weeks after the second one. So I tend to stagger them 6 weeks because I find that they don't need as much therapy for the second part of it. But for the same way, I guess if you were doing it closer together and you said, hey, we're going to have a little bit more of that protective phase before you get in. Same thing, just managing expectations.
I do 6 weeks as well. And then somebody wanted to confirm the crutches because, Dom used to love them and doesn't love them anymore. I don't crutch anything ever. I think crutches are terrible in this scenario. I wouldn't fault you if you did, but to me, the strength loss of not loading your quad for 2 weeks is very detrimental to recovery. I mean, they'll gain it back. I mean, you're not hurting anybody permanently, but you're slowing them down. So I don't ever put anybody on crutches. There's a question about, do we have access to this talk? I know Sunila is recording it. I don't know where that'll be. She could answer that. Someone asked about safety data and studies. They do exist. Dom's got some slides on them, but also a great resource would be discussing it with Hydrocision, and they have a resource available of that data to help with credentialing committees. There was a question about
oh, sorry, Nate.
There was a question about post-op protocols, post-op rehab protocols. And I think Dom, you and Jason have made some great videos. There's some great YouTube videos about those protocols that are in existence, because we definitely don't have time to talk about all of them individually, right? That's a whole nother 5-hour talk, but
yeah, there's also a supplement that we created that's a very long document, like 30-40 pages, that goes through some of the additional material. So again, reaching out through Hydrocision, they can give a lot of that additional material. And if you go to YouTube and search for Hydrocision's page, there's a whole load of videos that are on there. There's also things that they post on social media quite often, so on LinkedIn and different social media outlets that you can catch that will focus on one thing or another as the month goes through.
There's a question on how you fit diagnostic ultrasound into your practice. Nate, do you want to talk on that at all?
Yeah, I missed that. Sorry.
I mean,
every patient that walks in my door that I think has a tendon disease is getting a diagnostic ultrasound the first time I see them. I'm using that to diagnose them. I'm using that to talk about TenJet. I'm not frequently MRIing these to make the decision for what to do. I think we all know that the data on musculoskeletal ultrasound is better for diagnosing tendinopathy than the MRI data. Trust what you see. Trust your skills. I mean, we are the people that are trained to do this, that are trained to do procedural things with ultrasound. And sometimes we get afraid of our own skill and our reproducibility. Dom, I know you've done some good research on the reproducibility of diagnostic ultrasound and trained providers and fellows and attendings. And sometimes it's this, well, I know what I'm seeing, but I'm going to get an MRI just to make sure I know what I'm doing, right? And I don't see a need for that. I think as experience comes along, you'll see less and less need for that. I wouldn't argue with it, but the diagnostic ultrasound is what drives my decision making here most of the time.
Yeah, and you get patient buy-in. Patients like to have a procedure done that day. They like to have the ultrasound probe on. They like to look at the screen with you. You can bill for it. A limited diagnostic ultrasound is not hard to obtain appropriate billing for. You can set templates for a lot of this stuff and fill in as you can tab through. And so I agree. That's a big part of I really rarely go in a room without the ultrasound machine at some point. Putting it on a patient to either intervene or diagnose or both.
And somebody asked about going back if you didn't think you adequately debrided it. Certainly you could do that. The specific question about endpoint, pedal time. This is not 10x. This does not have a limit on how long you can use it for because there's no concerns about thermal damage, about heat of the device. So it's being done when you're done. Yes, less is more, not overworking healthy tissue and knowing what you're feeling, but it's the same tactile feedback discussion that I sort of touched on earlier for me. I don't know if you guys have a different opinion of that.
I think if you, Nate, you touched on it, and I tried to reiterate it a little bit. Using your anesthetic really kind of changes, in my opinion, you know, what you're doing, your plan and what you're doing, how much you're working, it really amplifies the pathologic tissue. So pay attention and use that anesthetic for a purpose, not only to provide anesthesia, but also it really gives you a great idea of how much pathologic tissue is there and the breadth of it, I guess. And so pay attention and use that anesthetic for a purpose more than just the anesthesia itself. That has really helped. And yeah, pedal time it's gone down and down as the more I've done because you get confident. I think that goes hand in hand with how I use my anesthetic. You get pretty confident at localizing the tissue. You saw the toothpaste video that Dom was looping. You put the device on the tissue and it's getting resected. You don't get bonus points for, extra resection of something that's not already that's already gone. So.
Yeah, and to the point of that question of how do you know you're done, I think we all have different analogies. I think Nate said it very well in terms of when you lose that feel as you're passing through that degenerative tissue. Another thing I said just a couple weeks ago to one of the fellows is they were trying to get that concept. Is I said, well, if you closed your eyes, how would you know you're done eating a container of yogurt? You just wouldn't feel the yogurt. You feel the edges of the cup, and you can't go through the cup with your spoon. That's healthy tendon tissue. You're done because you're done, and it removes you from it being a procedure that's time oriented to a procedure that's feel oriented. That's the other thing that I think sets apart TenJet than 10X, at least from a feel standpoint, is I could tell the difference in the tissue better with a smaller device, that the feel was coming more from what I was touching rather than this kind of reciprocating device. So yeah, I mean, this is definitely a feel based versus having to focus on how much time you've been pushing down on the pedal.
Either of you guys see any other questions I missed in the chat? I feel like I got most of them, but
Sunila jumped in and can provide material for credentialing, so definitely reach out to Hydrocision. Safety and efficacy protocols. And
then just to throw out, Hydrocision is going to be both at AMSM, AOASM. So come join us. I'm going to be at AOASM. We're doing 2 breakout sessions on tendinopathy. Some of this content plus some hands-on as well. So definitely we're reachable, and this should be the start of a conversation, not a standalone presentation. So we love talking about this, and we all 3 of us have said this before. We all learn. We learn every single time that we're on one of these calls from each other and from everybody who's doing this.
Yeah, I guess I didn't touch on, is TenJet covered by most insurances? And the answer is yes. I mean, the tenotomy code, again, the tenotomy code is covered by insurances, and differentiating that the tenotomy code is describing the procedure. TenJet is the device that you're using to accomplish the tenotomy code. It's not a TenJet procedure. It's a tenotomy procedure using a TenJet device to resect and remove the tissue.
I'll just throw in something, I guess it's off of that. So when we get procedures started in our health system, what we do is we do the authorization. So you do a standard authorization process. You submit the code to the insurance. They tell you, if it's covered benefit or not. You can have the patient call with the CPT code. You can provide to them. They can see how much out of pocket that's going to be. So that's a fail safe there. But also, if you want to check your reimbursement, because you don't know what you're going to get reimbursed, I always instruct people, because this is the way we do it and it's worked pretty well, is you don't do 100 cases and check the reimbursement. You do 5 cases and then you check your reimbursement. And so whenever we initiate a procedure in our health system, we do 5 of them, and we typically do Medicare patients, and we do 5 procedures and we check the reimbursement, and then we kind of dip into the commercial payers. So that's a nice way to start. It's a safe way to start. And it's something that you're able to do in a controlled fashion and check the reimbursement and go from there.
Yeah, and somebody just came in with a question about lateral hips, which is my favorite thing to do by far, about combining bursectomy and treating gluteal tendons and concerns billing both together. I mean, to me, the discussion is what you think the pathology that's causing pain is. To me, there's good data. We've got some studies showing that bursitis is not typically bursitis, right? Most of chronic bursitis has no inflammatory response in the bursa. There's no fluid in the bursa. It's the gluteal tendinopathy that's causing recurrent lateral hip pain. I don't think there's a need. When I stick this device into a gluteal tendon, if there's fluid in the trochanteric bursa, I'm going to evacuate that with the device on my way through. One of the pearls that I picked up from doing these talks is, that's a very neural area. When I'm done or before I start, I like to take the device and strip it along the top of the tendon in that tissue plane. I think that helps with the procedure, helps patients feel after the patient. I think somebody coined it tendon stripping, right, at one point. I've done it on every case I've done since that time, and I think it's helped. But I don't know that I think that the pathology that's generating pain there is the bursa in that scenario. So I don't know that I would see a need to combine it with a bursectomy per se.
Yeah, I don't disagree with that either. I mean, bursas get inflamed when they're infected. They get inflamed when they're, locally contused. They're full of blood. If you have trochanteric bursitis, you have underlying tendon pathology, very similarly to a subacromial bursa. Right now, you have an area where it truly can get impinged. There's probably not actually as much impingement if you don't have any subacromial spurring, but the bursa alone being the pathology, I don't think, if you're looking with ultrasound, that you've seen an isolated bursitis that isn't infected or is from like a hematoma, almost like a Morel leveling.
There was a pointed question on pearls for calcified tendinopathy. In my pro for that usually is very similar to the way I just used to do in office barbotages, is to take my local, run it right down to that sort of harder shelled calcified edge of it without piercing it. First pass, putting it right inside, running the device inside, and then coming back and trying to break up some of that shell. Here's a quad tendon that I did. Didn't get all of it, I guess. I'm showing you to show you my limitations.
It was just the 2 images that I found.
But the one on the left is pre-operative. This woman had years and years of pain. None of the surgeons would touch her open because they thought they needed to do a tendon graft. She was left with not a lot of solution.
There you go, buddy.
This was a single TenJet treatment, right? This was a one-time TenJet result. Her pain completely resolved afterwards. So I offered to go back and get the rest, and she declined because she was 100% symptom-free. She couldn't walk, she couldn't squat, she couldn't. I don't know who's this. You could pick any of us, and this probably looks like a shoulder at a couple of weeks, and then there's another shoulder. Works phenomenally. There's what it looks like in the bottom of the collection system afterwards. You can literally see it come out. So you're removing it. I always say, goal is if you get most of it, the body will do the rest. If I can get 60, 70% of it, I'll do a follow-up x-ray. If there's still some wispy stuff, it'll go away on a 6-week post-op x-ray. The problem will resolve if you get it started. So, those would be my pearls on calcific issues. They're great. They're very rewarding to do because you do them, and then in a couple of weeks you see an X-ray and you say, "Hey, look at all the good work I did." And the patient, even if they're not 100%, feels better just knowing it's not there. And then there's a question on any contraindication with connective tissue disorder or EDS, and we've talked about this before. I don't know if you guys want to talk about that, but
Chris, I think when we were chatting last night about it, you had a good way of summarizing that.
Yeah, a lot of the connective tissue patients that I've seen, really they maybe have tendon issues in terms of maybe inflammatory from typically maybe hypermobility of the joint. So typically their issue is not a tendinosis or tendinopathy. It's maybe a little more of a tendonitis, but the tendonitis is due to joint hypermobility. Either they have some subtle MDI or gross MDI in their shoulders, and their cuff is inflamed and irritated, and everything hurts in the shoulder girdle, or their patellar or quad tendon are irritated because they have some patellar hypermobility or subluxation or frank dislocations or something like that. So Dom, I think you had mentioned you had done one connective tissue patient. I can't recall ever doing one. I would not have reservation if it was tendon pathology, what that was their pain generator, or we were trying to treat the tendon pathology to then get at a means to an end to give them pain relief so they can, rehabilitate and strengthen and stabilize whatever joint or whatever capsule we're going after. So I wouldn't view it as a contraindication at all, but make sure your diagnosis is correct, because a lot of times those shoulders are inflamed and irritated, but it's not because the cuff is the issue. It's because the glenohumeral joint is the issue, and the cuff, they've lost the stabilizer in the cuff, so they need rehabilitation that way. So I think take-home point is it's not contraindicated if there's actual tendon pathology, or if you're trying to treat tendon pathology for pain relief to then rehabilitate.
yeah. And somebody asked about image capturing videos, stills. I treat this just like I would an ultrasound guided injection. I take a picture of the pathology before I do anything, and that's enough. And then I don't usually take more images into procedure. I don't think they're necessary.
Yeah, not necessary for billing
yeah.
at all. We for some of our residents, and we have a large number of residents and fellows, we need to give them something to do, so they'll hit the cine loop, take a video type of thing, and they just feel like I'm contributing, which they are, right? But we normally have a lot of videos of ours saved. But to Nate's point, you need an image saved of it, just like you're billing anything else.
Yeah. Somebody asked about large rotator cuff lesions and insertional integrity causing pathologic tearing. I haven't experienced. I've taken out some colossal rotator cuff calcifications because again, we're not removing anything that's structurally healthy to start with that's already there. So we're taking out something that shouldn't be there. We're not hurting what's already functionally working. So we're not going to create tear if it wasn't there before. So I wouldn't worry about that. And then Dom, I think you love to talk about this. In what situations or tendons would you not use TenJet? Anything jump to mind?
Yeah, I mean, anything that's smaller, that's going to be harder to fit in. So a lot of the small things that you're going to see in your wrists, you might see some ECUs that have some chronic tendinopathy to it. I'd probably stick away from them. Well, not necessarily stick away from them, but those might be a little bit harder. Some people don't do I don't do a lot of long head bicep tendon. I know there's some people who do. I've done one gracilis because we had a hip surgeon who asked us to. She was a former marathon runner who was down to 5Ks, who ended up doing really well. I mean, it's what Nate said. Have great relationships with your partners, and like, how do I approach this, right? I mean, you're the one who sent it over to me. Help me understand how I'm going to approach it. She's done very well. We've done one. I'm not looking to do more of those. That technically that was a pretty difficult case, but it stands to reason. If you have a tendon with tendinosis in it, TenJet resects and removes it. So if you feel comfortable getting the needle there, you should feel comfortable doing the procedure. There's a lot of things that we did once that now are done thousands of times, right? So I think feel comfortable with the skills, as Chris had said as well. Convince yourself that you can do this and you are the right person to take care of it. But be careful what you ask for, right? Because you are the person to take care of it. So you got to have the community, build the community. And I think that's really what Hydrocision's done well, is build an educational community that can lean on each other.
Chris, I know you do long head biceps. I do long head biceps. I know you love doing perineals. Have you ever done ECU? Is there something that you
Yeah,
would?
I've done ECU. I've done hand and wrist tendons. I think if you could get that cutting window to the pathologic tissue, you can do it. And I've done ECU, I've done APL and EPB. I've worked on tendons in the hand and wrist. I've worked on the posterior tib, the longus and the brevis, the peroneal longus and the brevis, and the foot and ankle. It is a little. Those would not be the first ones that I would do, or the second or third
I'm
one.
sending them down to you, Chris. You got them all, buddy. No problem.
But honestly, because you have a lot of needle tip, as Dom mentioned, the dimensions, you have a lot of needle tip, but the cutting window is where the work is done, and so you have to plan. And like I said, I wouldn't do it as your first one, but I think I've had those patients do very, very, very well. And if there is pathologic tissue, you can resect it with this device, and yes, you can do it. But I would get a couple under your belt before you went that way. So really, I think my opinion on it is if you can see tendon pathology with the ultrasound and you have enough needle tip to get there, and you're confident in your skills, then you can perform this. Make sure you're diagnostically accurate in what's causing the pain, and you can do this treatment. I use diagnostic injections frequently if I'm not sure. I'll put some anesthetic around the tendon in question, and the pain goes away. Then that's the tendon, that's the problem, because sometimes we see pathologic tissue that's not actually pain generating, right? And so if you can put anesthetic around a tendon in question and the pain goes away, then you can also resect that tissue and should get a similar result. So I use diagnostic injections very frequently for some of those odd ones. The one tendon, I mean, I think, I hope this goes without saying, but obviously if you have, greater than 50% tendon tear, a thickness tear, in something like an Achilles, you're sitting at a 70% thickness or something like that. There's probably there is a more appropriate treatment for that. Rotator cuff in a 48-year-old that has a 70% or 100% supraspinatus tear. Obviously, you're not going to debride that. So I hope that goes without saying, but I'll say it. Those types of tendons I would avoid, but outside of that, I would get after it. And tendons that matter if they tear, like I mentioned lateral epicondylitis and lateral epicondylosis. At one point, and still I think there's some physicians that probably do this, orthopedic surgeons, like the treatment was tendon release. You release the ECRB. Like, oh, okay, so if you have an 80% ECRB tear, does that matter do you need to repair that? No, because some physicians repair that, some physicians release that, some physicians debride that. TenJet works extremely well in that scenario where, okay, if there's an 80% tendon thickness tear in the elbow, does that matter? Distal biceps? Yes. Lateral epicondyle, ECRB? Not really, because like I said, some physicians release that, and that's the treatment.
Yeah. And then, so Chris, you hit the next question in the chat already, so that was perfect. And then work with enough joint surgeons long enough, absolutely, you're going to be getting questions about iliopsoas tendinopathy after a total hip. What are you guys doing at the clinic when you're getting those, Dom?
There's only a couple places around the country where you see the clinic and people know what you're talking about, right? But what I'll say is if you have somebody who comes in and they say, the day as soon as I got done with my hip replacement, I had pain in the front of my hip, right? They have iliopsoas as abutment. They're running on the front of their cups. You can do a diagnostic injection. That person probably needs a release, right? But if you the other patients who fit into there where it kind of chronically came along over time, what you still end up finding is they might not have abutment, but they might have a lot of scar, and a hydrodissection may actually serve them much better than trying to go in and look at that insertional part. Majority of their pain isn't coming from the insertional tendon at the femur. It's normally coming as it crosses across the cup. And again, if a really good diagnostic ultrasound will show you where they're catching and where the majority of the hyperemia is. Those are cases where, again, I'll go back to orthobiologics. That's where PRP works well, is for chronic iliopsoas tendinopathy post-THA that didn't start to occur symptomatically right after the surgery. It took 6 months or maybe a year before that came on.
Yeah, usually, though, I think they respond really well to just the dissection. I
Yeah.
good response. But somebody who had pain forever, they end up back to the hip surgeon. That's the treatment that works for that.
We still got 45 people on through the whole talk, so this is great, guys. This
Yeah,
is
questions
not really
trickling in.
another opportunity.
Yeah, these
Um,
questions
yeah.
are really awesome.
If anybody has anything else they want answered, now would be the time to drop it in there, because
And if we missed your question, just copy it and paste it back at the bottom so we can, if we have a question and you're still on and we didn't answer it, I think we got them all. But for sure, if we didn't, copy it, paste it back at the bottom and we'll get it now.
Yeah, and if something comes up, reach out. I mean, Sunil is a great resource that can put you in touch with us if somebody has a specific question they want to talk about. They'll frequently do follow up. Hey, I wanted to talk about this thing in more depth. I know I'll speak for myself, but I know I'll speak for Dom and Chris here too. We're always available. One of the things we love is talking to colleagues and having these discussions and sort of growing ourselves along with it.
Another pearl that I'll just throw out there, since there are like so many people on still, is talk to your coders. So we talked about billing, coding, documentation, reimbursement. A nice thing to do as you're getting going with the procedure is give them a sample template of what you're going to do and ask how they would code it. And if they come back with, this is a tenotomy code and this is how I would code it, then great. If there's an issue, iron out the issue beforehand. I've had some growing pains with our coding and billing team over the last 8 or 9 years here, and what I've really found is frequent meetings and discussions are extremely helpful versus finding out about something later down the line. So a nice thing to do is give them a sample of a template you're going to use, and then have them give you the what they view as the appropriate code. And if it's not the tenotomy code, ask why and really delve into that and see what is needed, and maybe it's an error in your documentation or you're omitting something that needs to be included that you're actually going to do. So that's also helpful. Treating calcific tendonitis along with partially torn cuff tendon, same tendon. Do you bill 2 separate codes? So the tenotomy would be single or multiple in the shoulder, if that's what you're referring to. So if you're debriding one tendon, I bill one tendon. If it's more than one, which happens frequently in the shoulder, then I'll bill the multiple.
Unless you're making more than one incision to do that, then you can bill a multiple and a single. Like if you're going to do supraspinatus and infraspinatus, and then you're going to come hit the subscap. If you need to make a second excision for your approach to do that, you can bill more. You can bill an additional code when you make the second incision.
Nathan, good to see you, buddy. And thanks
Sorry,
for being here.
I don't know. I got kicked off. Somebody kicked me off. It may have been Sunila saying enough.
You just get here, Nick. You've been here the whole time. Go ahead.
The other one, want to just throw it out to, hey Nate, good to see you, man. The outpatient procedure clinic, how often are you doing twilight meds prescribed? I think this is probably where there's there's probably more variability in this than probably any other part of the procedure. I would think. You guys tell me what you think, but my pain control is anesthetic and a needle. That's it. Right afterwards, if they want to put some heat on it, Tylenol early on. Normally that's what I go to. I don't hold them from NSAIDs or ice. It's just NSAIDs and ice decrease inflammation. I don't mind that thing being inflamed and healing what needs to heal. So I don't use. The only thing is if somebody's really nervous and they have something that they've had in the past, or their PCP's writing for them just to take down some anxiety. But yeah, it's the liquid and needle. You guys?
Yeah, that's mostly what I use as well. I will use a benzo if requested. I don't have a problem giving one for the procedure. We set the ambiance. I play music. We talk to them the whole time. Hopefully it's good music, but usually classic rock. Everybody kind of at least knows it or kind of likes it. But yeah, I use the anesthetic. That does most of the work, and that's probably good for 98 plus, maybe 99% of patients. And, then there's, the couple percent, 1 or 2% where, requesting a benzo, I'll give it. And then post procedure, rarely, but I really don't have to do much more than, sometimes I'll give tramadol if someone calls me on call and they're super uncomfortable for a day or two. I'll give them a short course of, a couple of days of tramadol or something like that.
Yeah, this is where I probably differ. I offer everybody twilight. and a lot of people take me up on it. It's a little bit more efficient because I don't need to wait for the anesthetic to kick in before I start, and get it done. But I offer patients both. I'll do both, just local, but then afterwards I do nothing. I can't tell you the last time I wrote a prescription for anything for pain control after I do these.
Julia just put another question. So cash practice, do we have to make a cutting incision? My understanding is it was needed in order to classify the code as open for insurance reimbursement. Nate, you kind of touched on this a little bit earlier, but essentially when you talk to a coder, because I've talked to coders a lot of different ones, consultants and otherwise, they can't tell you how big the incision needs to be. So you are penetrating the skin with the device. A lot of times it's a lot easier to make an incision with a scalpel to actually get the device through the skin. But I've had multiple conversations, multiple coders, a lot of them, and they can't tell you that the incision has to be 2 inches, has to be 1 centimeter, has to be 2 centimeters. The most often thing that I hear is, well, you as a physician know if this is an open procedure or not, which does that help anyone? Doesn't help me at all. So essentially, no, you don't have to make a cutting incision for the classification as open, but it is helpful to gain access to the tissue. That's kind of my, yeah, exactly. Cash only, you don't have to, you can do whatever you want with cash only. Yeah. So if you're cash only, insurance doesn't even matter. Just document what you did.
Yeah, my caveat would be like just a really little nick. It makes it easier to penetrate. So it just, you don't have to, but I think it would make your life easier to do it. And you can control the incision. You can be certain of where it goes. I think I would still do it. If reimbursement was out on the thing, I would still do it because it would make my access point a little easier.
Yeah, I mean, essentially you describe, do you have to put, so this is this can be open for debate and interpretation. Do you have to look at operative notes? Do you ever look, from your orthopedic surgery colleagues, do you ever see, I made a 3-inch incision to access to get portal access, for my, arthroscopic procedure on the knee. Like you don't see that. So, you describe what you did in some detail, where you, incise the skin, and describe that, but you don't have to give detail of how you did it or essentially what you use. So that's where discussions with the coder, if you're cash based, like I said, it really doesn't matter, as long as you just describe what you did. But a discussion with your coder, maybe they're looking for that. Some are, some aren't. So that's helpful.
You can debate that the needle tip of this thing is making an incision in the skin when you go through it. So
right. So you describe that in.
Yeah. But I think your technique is easier if you make a really small incision just to sort of get through the skin and control the tip through. So that would be my advice. It's just, I think from a procedural standpoint, it's easier to do it.
Agreed.
I'm impressed. We got 31 people still on here. So thanks to everybody for your dedication to improving the lives of patients with tendinopathy, even close to depending on where you are. I think we have a couple international people on as well. So awesome to have the breadth and depth.
Yeah, this is great.
Yeah,
Any
really
other
appreciate
final questions? Anything else? Sunila, Elaine, any final thoughts?
Well, first of all, thanks to all of you for staying on. We've 45 minutes beyond our time, so that was great. And
that never happens with us, does it, Sunila?
That's right.
Never.
You love to talk. You love to talk about it. So I think that's
And you guys started an hour before, by the way.
That's right. So thanks everyone, and I look forward to seeing you at the conferences, AMSSM and ASM, and definitely the TenJet team, your sales representatives will help you get through the process, get through approvals, and our faculty will be here to teach when the time comes. So thank you for attending.
Cheers.
Cheers.
Great. Thank you.
Take care, y'all.